Hello everybody and welcome back to this topic. We are talking today about the functional analysis in the extensive rehabilitation cases. We will talk about occlusion, the relationship between occlusion and proximal activity. We will talk about the CR, we will talk about the video, about many other aspects of the occlusion that will be maybe important in the final rehabilitation cases. So we try to follow a kind of predictable approach, a predictable clinical approach. So let me start saying that after the aesthetic analysis, of course, our duty is to understand what about the function of the patient. We have to remember actually that we need to create a situation in which we can achieve a stability of the stomatognathing system, having reached the joint stability, the dental stability, and of course, the occlusal stability. That will be, of course, the ideal situation for us. The main goal of our treatment when you do extensive rehabilitation is to create the proper occlusion. And actually, we should first of all, optimize the function, having the chance to minimize the involvement of the masticatory muscles, minimize the load on TMJ, so extending our restorations up to the first molar at first in order to really protect the TMJ, and control the load on teeth. It means dissipating the load in every teeth if we can, and so as many as possible are to be involved on this kind of occlusion pattern. So let me start to define one important step, that is the maximal intercuspation. That is also called acquired position or habitual position. It means that we have the posterior teeth that are aligned in such a way that vertical forces are, of course, placed on them with no adverse effect. In normal occlusion, we have also normally a light contact on anteriors, but sometimes we have also the lack of contact on anterior area. But mainly, we try to have a light contact on anteriors if we could. So just to say what we should say to idealize the occlusion on teeth, we should have, of course, occlusal stability on posteriors. We needed to have synchronized, equal intensity, punctiform posterior contacts, quite marked one. Then, light simultaneous contact on anteriors, and having the chance to form a kind of anterior guidance that can disclude the posterior teeth during excursive movements. So it means that you have no interferences when you go right and left. So posterior disclusion is the last step, but very important one. So what about implant cases? There is not so much difference. The concept is the same. Of course, the occlusal table will be narrower to avoid to have an overload on the cantilever area of the restoration. So but the anterior guidance is still the one that we normally try to found in function and parafunction, and the posterior occlusal form of low cusp incline and central fossa location of opposing supporting cusps in CR. In CR is in centric relation, of course. When you do the entire case, that is something that we believe that is obliged to follow. We must follow the CR position. I will discuss in a while about that. So, occlusal anatomy. Today, we believe that it is not anymore necessary to have so many contact points on occlusion. We have been used in the past years, in past decades, actually, the tripods occlusion, but is really very complicated to achieve and maybe not needed. So, according to the Wiskott-Belzer article in 95, a substantially reduced number of occlusal contact in a maximum intercuspation is normally advised. So, interarch occlusal contact are only present normally if you need to choose one of them on the buccal, of course, the buccal cusp of the lower teeth, so the centric cusp of the lower teeth. So, what else? What is the characteristic of this kind of occlusal scheme that is simplified, as I said, the clinical guidelines? One occlusal contact per tooth for axial stability is already sufficient, even though, of course, if you have two, you don't have to remove it, of course. So we should also create a kind of freedom or close to the contact, occlusal contact. We have a concave topography, mesial to upper bearing surface, and then proximal contact to stabilize the teeth major distally, so we can maintain the position of the teeth, having very nice contact areas between the teeth, the one forward, the one on the back. And then, as we said, condylar guidance. Condylar guidance normally is believed that it should be regulated to 20-25 degrees, the condylar eminence. Condylar eminence quite flat in order to have the chance for dental technician not to create so cusped anatomical form that is too much, too heavy, too important, because then you can have something interferences. If you put the 20-25 degrees on the condylar guidance, you will have a quite low space to build up the walks up and the restorations, so the technician never go up too much and never touch during exclusive movements. So you have no interference in this area if you have 20-25 degrees on the condylar path inclination into the articulator. And then I have an anterior guidance that is the one that you wanted. So it will be quite flat. We will see later on. So function. We have to remember that we discuss most of the time, especially aesthetically speaking, about the 6 upper anteriors. But we forget many times that the 6 upper anterior are related to the lower arch with the 6 lower incisors and cuspids that are there. The ratio between them, the relationship between them, upper and lower arch on anterior area, can create a kind of overjet, horizontal discrepancy, and overbite, this vertical discrepancy. So normally we have a value about 2-3 millimeters. It's of course an average value. Then you have to go to the mouth of the patient, customize your guidance, looking the patient as they move the mandible in an easy way when you have achieved the right result, a clinical result. Remember that for every 10 degrees in change of the angle of disclusion, there is a 35% change in the force that are applied. So it means that you can have the chance to really flatten it tiny bit, the occlusion, the guidance, and this way you obtain much better situation, functional situation, because the muscle activity will be lower, is reducing the muscle activity as much as you go flatter. Of course, not so flat that maybe you have touch on the back area, but just flat enough to see the patient move the mandible in a very easy way. Regarding this anterior guidance and the other kind of different kind of solution, we can say that we have the chance to have normally cuspid guidance or anterior guidance when you move laterally, cuspid guidance the right, cuspid guidance the left, or even group function. Group function when you see the involvement not just of the cuspid but also of the bicuspid at least. Some other authors goes up to the molar. So altogether they work quite well. So, and then we have also the chance to use the balance, the bilateral balancing contact. That is another scheme that we will discuss in a while when you touch also the contralateral part of the molar. So, the 3 groups of this article, canine guidance occlusion, group functional occlusion, and bilateral balance occlusion, that are the 3 examples that was came out from this article, a systematic review in JPD in August 2015. So when you use the canine guidance occlusion, you have to understand that you have at the end less muscle contraction during clenching, no posterior contact laterally. It's very easy to perform because you have to take care about one tooth only, the cuspid. But you have to remove all the other contacts, so you don't have to do very detailed changing. This means that it's easier. Seems to be protective for posterior teeth because we have a narrow mandibular pattern with less oblique forces, and the canine guidance occlusion can also cause a more superior condylar displacement than group function. So the most important, no posterior tooth contact laterally, easy to perform to adjust, and less muscle contraction during clenching. When you use the group function occlusion, you have more efficient chewing, more comfortable, at least the patient referred that, but you have a wider range of lateral movement during chewing. So you have more stress laterally for posterior teeth. And of course, you have also more occlusal loads during maximal clenching. But big advantage in this case, if you have a kind of tenderness or problem of TMJ area, is very important because if you have a group function, you can protect in some way the TMJ. Last but not least, the bilateral balance occlusion. So we have protected against compressive TMJ loading, causing fewer incidents of joint noise. But at the same way, we have to consider the more load on posterior teeth during exclusive movements, and that can be dangerous in another way. So I believe that it is important that the lateral occlusion scheme has an impact on muscle activity, we said, in mastication and also in the movement of the mandible. And the canine guidance appear to exhibit more of protective role than other kind of occlusion. At the same time, the group function results in a quicker mastication and more comfortable mastication, as the patient said. The canine guidance is also associated with the less electromyograph activity during parafunctional activity, while the bilateral balance occlusion was clearly associated with the greatest electromyographic activity. That can have an impact on the muscles, of course. That is not great. So just to summarize, to let me understand better with you what will be the right thing to do with the healthy joint and the compromised joint. We believe that in case of a healthy joint, we normally use the canine guidance. At most, if you have the canine that is not reliable abutment, maybe it's an implant that is questionable, or I don't know, the tooth with no good support from periodontal point of view, you can have maybe group function that we extend the group function maximum until the second bicuspid, not on the molars. But you have some freedom in centric, and we should avoid any kind of balancing contact. On the other case, when you have a compromised joint, we can use the group function instead of the canine guidance, still being a freedom in centric, and having balancing contact to protect the TMJ, as we said already. Let me give you an example of a case that we made, extensive rehabilitation case, as you could see from this picture. Is moving frontally, we're not touching on the back like it happens for the guy on the right side. And you see that he is also able, this patient, to move quite rapidly, right in front, lateral, one side, other side, without any problem. So no restraint. It was a freedom to move easily. It means that we have a cuspid guidance in this case, but it's moving very well. We have not steep guidance, just quite flat guidance, and the patient is able to move easily. So let me now start to talk about one myth of occlusion, centric relation. And I would like to say it's important when you talk about centric relation to say how, when, and why, probably every few years. And you can see that if you look at the CR definition, you see the definitions are really different one, each other. Today, what is the most validate is, of course, that is the anterior superior position against the eminentia. So, even more recently, we have some study of 7 dental schools, resulting in the conclusion that there are not consensus on the definition. Still fighting each other, many schools. That is even, more new article that was published in 2017 about definition. Disagreement and confusion continues regarding the definition of CR. Some of this disagreement can be explained by training era that they are different in each part. So let me just give you some information about the disc that is always positioned between the condyle and the fossa is properly aligned with on both condyles. That is, of course, the first step that you should remember. The condyle disc assemblies are at the highest point possible against the posterior slope of the eminentia. It is braced by bone. So the middle pole of each condyle is braced by bone. And the lateral pterygoid, the inferior lateral pterygoid muscle, have release, contraction, and are passive. That's happen always when you go to CR. The lateral pterygoid become less involved, absolutely. The TMJ can accept a firm compressive loading with no sign of tenderness or tension. And that is what you should find when you go to the CR. So that is what happened now when you see the disc in yellow. You see behind the disc there is the posterior ligament, reach the vessel and nerves, but not loaded at this point. They loaded the condyle against the meniscus through the disc that is properly aligned. So we have no pain or loading, as you could see. But not always like that. Sometimes you are going to another kind of situation in which the patient had already this kind of displacement, is permanent displacement of the disc anteriorly, like a closed lock. So you cannot have a locking or closed lock. So you cannot reduce anymore the position of the disc that remain displaced anteriorly. And now you see that all the posterior ligaments are in the place of the disc. And initially, being rich of vessels and nerves, it will be a very painful area. But then, over time, become later on fibrotic, acts as a second disc, kind of second disc. That's the reason why Peter Dawson in '96 coined a different kind of term, that is adapted centric posture. And as you could read here, the most superior position against the meniscus of the team J that have undergone various degrees of structural deformation, but have adapted to an extent that they can accept firm loading with no discomfort. So we have displaced completely the disc. The disc is no more functioning. The posterior ligament becomes fibrotic again. It acts as a second disc. If you have this situation here and not painful, it will be possible to keep this as a new CR, even though it's not classic CR, because you have not the disc interposed, but still you have the chance to use the same maneuver, the same way how to record the CR through this kind of new disc, that is a kind of new disc, that is the posterior ligament that was under deformation, that have adapted anyway in extent that they can accept film loading. That's what they said already. So, next question about CR. When we use this CR, we use all the time? Not, of course. We can use in many cases, but not always. Just let me give you a couple of them, not to talk about everything because it's too long, but at least when you have to do one arch or two arches, no doubt, we go to CR. And we have a presence of attrition in the anterior area also is another situation in which we go to the CR either. So then it can use also for, of course, to do the athletic grounding on the patient with the temporomandibular disorders. We can have use for bilateral equilibration, for after ortho finalization, etc., etc. So, but why use CR? The reason why you use CR is mainly the one that you see here. You cannot avoid to use CR position when you have to do one arch or two arches. As Jeffrey Ockerson wrote in his book, it's really easy. The MIP, the maximum intercuspation position, the acquired position, is completely determined by tooth contact. So it's a tooth position. And when you prepare the teeth, absolutely at this point, you eliminate all the contact, causing that this kind of position will be automatically lost. So we are really, going on space. You have no more any reference. So the optimal mandibular position CR should be used regardless of the patient tolerance of MIP. Anyway, if you want to really be sure that you do a kind of extensive rehabilitation, there is no doubt what you have to use. But why use it? Reproducibility. That is the most important step. Once you are able, as we describe in our other lectures, that we need to copy a provisional or even the mock-up that are reproducing what we need to achieve as final result, having checked all the aesthetic and the functional parameters, and you have your prototype already on the mock-up or on provisional, you want to copy. And to copy that, you have to do the cross-mounting procedure. To do the cross-mounting procedure, of course, you have to find all the time the same position of the mandible, the CR position, not to find 3 bite records different each other. We need to find all the time the same position. So repeatability is very important. McKee 97 did a great job with the train groups they have seen in 97, as said, published in JPD. And actually they found that the train group were able to achieve the same result after 1 day of trying. So again, this is the reproducibility is the great result that you want to achieve, especially if you want to do the cross-mounting. If you want to copy something that was working well, it was tested, they proved in the patient mouth, to go to the final work. So that's the best way, is to really have the chance to copy this situation. And you need to have the same position of the mandible all the time, the same video at the same position when you do the full mouth rehabilitation. So it's much more important the repeatability of the position than the precision of the position itself. That is an important step. You have to reproduce each time this. Then you also decrease the muscle activity. Is an orthopedically sound position, is a kind of border position, so you have no chance to say that is not possible to repeat. So again, this article by Pokorny and my friend Aaron Litvak, they said the CR should not be dismissed as a treatment position of prosthodontic convenience. Convenience, it means that is important for us, is a repeatable reference point, as we said already. How to do it? We have different methods. Each one of us can use what they wanted. We normally use 3 of them, or even 4, by manual manipulation by Peter Dawson, the lift gauge, the Lucia jig, and the anterior deprogrammer. They are the 4 that we normally use, that we teach during our courses. So, bilateral manipulation, lift gauge, Lucia jig, anterior deprogrammer, they are the 4 ways how to really work on this kind of CR records. But before starting any procedure, we should really obtain a nice CR with bite record. You have to relax the patient. You have not to have a noisy area around you, like you should do in your room with the patient, not talking, nor laughing, not doing nothing, just relaxing the patient. Should be really relaxed. Of course, not always possible at the first step to guide the patient in the perfect position. But again, it's very important. I believe that at the end, everybody can achieve. Also, in our groups that follow our courses, everybody at the end are able to achieve the same result. So it's really repeatable, reproducible, very, very, very well. So any procedure used to achieve a correct bite registration in CR can be verified if the material are not adequately known, managed. Like, let me give an example. Many people use still the Beauty Pink wax from Moico, maybe different today, but many of them have been used for many, many years. But not many dentists know that you should have a temperature of the water that should be fixed in that temperature, like about 54 degrees Celsius. So it's very important how you use the material and knowing what are the characteristics of the material itself. So let me say, should be simple, reliable. Bilateral manipulation have the advantage to be efficient, rapid, and what is the most important, you can feel the CR, you can feel the condyle sitting in the proper way, if you have a little bit of experience. Many people use too much force to maneuver this mandible. Shouldn't be like that. Should be like a shaking the mandible to find it. Very easy. And of course, repeatable during the entire procedure. But of course, you have some disadvantage. Among the learning curve that should be quite long for many, maybe not expert people or dentists. But of course, you have a big disadvantage when you have a big muscular contraction. So you cannot maneuver the patient the proper way. So you have to use something to relax the muscle before, like an anterior deprogrammer or even another bite, occlusal bite. But then you have to use the bilateral manipulation only after that. Leaf gauge is very easy to use. I believe that most of the people that follow our courses, most of them are using this leaf gauge because they found that this is the easiest one. Of course, it can be used also to have the load test to understand if you have a muscular or articular problems. And is repeatable also, is comfortable, is adjustable. It can be perfect when you do, for example, an occlusal adjustment in CR. You can use the leaf gauge to be it will really helping helping us to find the right position. Disadvantages: lack of feel. The only one that you can feel it is the by manual manipulation, of course. All the others you cannot feel. You have to see the patient moving in front and back and clench, front and back and clench. And some authors have seen in the past year, mainly, that you have the risk of some distalization of the condyle, but it's still a controversial issue. Lucia jig, advantages: reproducible, and also here, and does not distalize the condyle as should be, maybe according to some authors, for leaf gauge. Muscle set condyles and deprogram the muscles as first. Lack of feel is one of these advantages. Not easy adjustable and not able to be used for the entire equilibration procedure as the leaf gauge is. So we have some disadvantages that is more complicated to use. Let me now change my topic after having treated with you the topic of CR, MIP, and adaptive centric posture, and a different way how to record the CR. I would like to really open this kind of discussion about the vertical dimension. Vertical dimension is something that was needed in this case, as you could see from the two stone models. You couldn't avoid it to do differently. But when you increase the VDO, of course, you have to have different concerns, and we have to ask ourselves different questions. First of all, is it possible to change it? Second, what happens when we increase it? And then, how to decide the amount of increase, and how to test increase. That all 4 questions that has to be absolutely answered. So, let me start with this. First of all, when you have to do a case like this, that is a complete rehabilitation case because the patient was completely worn out, I could see that after having followed the indication from the dentist, so from myself in this case, about how to change the situation, the beginning situation to the final one, after having checked all the aesthetic and the functional parameters, you have the workshop. In this case, is covering completely the initial model. So it's still possible to do a kind of mock-up in this case because we have add volume 100%. We have not touched the model underneath. So it will be possible to have a reversible kind of solution. So again, you have a check together with your team the aesthetic and functional parameters, and then you have the chance to have the prototype for the mock-up and provisional. It has will be now in wax, but then we transform in maybe acrylic or maybe in bisacrylic. So what we need to indicate to dental technician to do this kind of workshop and to have the chance to optimize the level of the final work. First of all, we have to determine the incisal edge position of the upper and lower teeth. That's the first step. So it should be, first of all, for dental technician, change the anteriors according to what the dentist sent to him. It means all the instruction, how much you have to increase the length of the upper, increase of the lower, how much you have to change the overjet, the overbite. So all these steps has to be founded and, of course, made on wax by dental technician. Then, third point will be the orientation of occlusal planes. Of course, we look at the patient in front of you and try to understand what is the orientation that should be founded, should be finalized for patient. And then, of course, the occlusal posterior stability in CR, that is very important. Again, with marked contact, with equal intensity, synchronized punctiform posterior contacts. And then, the anterior guidance with the incisal and cuspid guidance, just in case you want to have an extension of the contact posteriorly, you have a group function, you have discussed already. But anyway, with the anterior guidance or even group function, you can avoid any posterior interferences, at least in balancing contact. Last but not least, the last part of our kind of description of what we would like to optimize is the the video determination, the determination of the vertical dimension of occlusion. All these steps are indication for dental technician. So can be actually indication, can be recommendation, can be what you want. It's something that the technician should receive in order to change the initial case to the final case. But the final case is made in the works by the technician. But of course, all the content inside the workshop will be the content that was achieved by the dentist through a really particular care about the aesthetic and functional parameters. So that was the beginning, that was the end. We have increased in this case quite a lot the video, around 6 millimeters. We could see that we have already written in our lab chart, in our get-up, of course, the increased vertical dimension, how much maxillary, how much mandibular, of course, should be signed and not invented by the technician that has not the patient in front of you. So you should say you have to increase the length of the lowers 1.5, and then you can add 2 millimeters on the lingual, on the palatal concavity of the upper teeth. You should be the one that define this, inform the technician about it. Technician cannot know. They don't see the patient normally talking or laughing or just speaking. Okay, of course you can do a movie and send to him, but it's our responsibility as dentist. So upper or lower, that's the question. And then you do the workshop, mock-up, and provisional, we said. So now is a rapid way to go. That is, again, a mock-up that we put in the mouth. After 5 minutes, is a bisacrylic. We put also the lower arch. These 2 arches that were completely destroyed was completely renewed. And the patient is now possible to have this kind of new setup. And we have to check it. If this setup is the one that you want to achieve as final result, or you modify a little bit maybe. We try to have the best occlusion, of course, together with the best aesthetics. And once you have achieved this kind of result, we have the way how to really improve the final outcome. So, vertical dimension of occlusion. Again, sometimes you can decrease, because if you have a small overbite, important overjet, long face, class 2, and skeleton open bite, we should theoretically also decrease the video, but we don't do it. Why? For a simple reason. Because if you decrease the video, you will destroy your teeth underneath, your abutment underneath. So that is an option that I normally try to avoid it. And fortunately, it doesn't happen so often to have the kind of need to decrease the video. Sometimes you conserve the video because you have people with osteoarthritis, and maybe an elderly patient is to modify not so rapidly the video. But the most important step when you have increased the video. When you have important overbite, you increase the video and you decrease the overbite. So it's better to have a better anterior guidance. When you have a small overjet, you can increase the video, automatically you increase the overjet too. For each millimeter of over increase of video, you approximately increase 0.6 of the overjet, more or less. And then you have a short face, you increase the video, you have a better maybe view of your face. Class 3, edge to edge, you increase the video, you increase the overjet automatically, so you can create a different kind of situation. So we can create finally an overjet that was missing before. And the skeletal deep bite, of course, is also another case in which you do it. So, but anyway, that is a kind of final suggestion that you can follow. But of course, what we normally do is try to find a way to increase it, not to conserve, not to decrease. Why? For a simple reason. The most important reason is to find a space for restorative material. For restorative material, without touching the teeth, without preparing the teeth. More than that, if you increase 3-4 millimeters anteriorly, you can have to rectify the occlusion as you like it. You can rectify the aesthetics as you like it. And if you increase it, you cannot have to grind anymore on teeth, reducing the thickness, the height of the abutments, reducing the presence of enamel. That will be crazy. And reducing to the need to do any kind of surgical crown-lengthening procedure, any kind of endodontic treatment, any kind of post-encore. That is a very traditional way how many people are still doing. So that is the big advantages in what to do when you increase the video. What about, we had some concern at the beginning. Can we do it or cannot do it? And the first answer is we can do it. Of course, yes, because this is an article by Abduo. It's a review article, systematic review, among more than 900 articles. And whenever indicated permanent increase of the video up to 5 millimeters anteriorly, seems to be a safe and predictable procedure. And if you have any sign or symptoms at the beginning, you can have a kind of release of this problem with a tendency to resolve within a couple of weeks, 2-3 weeks. That's interesting. But more than that, many people said, yes, I can do that. What about the TMJ problem? The TMJ can have a problem, tenderness or tension. That's an article by Jeffrey Okeson that say the stomatognatic system has the ability to adapt rapidly to moderate change in video. So there is no indication that permanent alteration in video will produce any kind of long-lasting temporomandibular disorder symptoms. So it's not a big problem. So with my group, we made about 100 cases on full mouth rehabilitation. So big number. We study many steps, but we have not the time to really talk about all the steps. But just to give you an example. So 100 rehabilitation, 1 to 10 years. We have collected data, age, gender, symptoms, parafunctional, rehabilitation type, etc., clinical aspects, and post-operative evaluation of freeway space, adverse event within 2 weeks, adverse event between 2 and 8 weeks, etc., etc. So let me explain to you the 3 groups. The bigger group is the mixed supported. So it was 56% when you have almost every teeth with 1 or 2 implants or 3 implants on posterior area. So it's mainly teeth, are mainly teeth. Then the white one, 25% is just teeth, 19% just implant. So full teeth support, full implant, and mixed support. Let me explain to you. What about the increment of video? The increment was average 3.3. We don't need more normally. It's difficult to say what is normal, but anyway, 3 or 4 millimeter maximum is 90% of my cases at least, just to give you an idea. On implants, it will be much more, 5.4. Why? Because you have no reference on teeth still there in the mouth. So we need to say that is nothing actually as a reference. On the mixed supported, because are mainly teeth, you are close to the full teeth support, 3.6. So the average could say 3.5, 3.5, 3.8. That's what the normal increase in the video normally. What about the freeway space? Because we increase the video, we occupy the freeway space, but the free space will be regained in a while. And you see after that, full teeth support, now 2.6, 2.8, 3.1. So each one of the group found back to have the very nice new kind of freeway space. Normal one. So what about the adverse event within a couple of weeks? Look how many steps we have found. Tenderness of masticatory muscle, difficulty in chewing, difficulty in speech, especially with S sound, as you know. S sound is considered the closest speaking space. If you create the video, you can have some difficulty in speech until you are not readapt to the new situation, to the new height. Soreness of teeth, grinding, clenching, headache, elevator from bite forces, muscle and joint fatigue. So let me show what will be the important here. So, no one of these kind of adverse events were on the patient in 83% of the patient. Only 17% of my patient at the chance of our patients, were found to have this kind of one of these problems. But 83%, nothing. Even though they were informed about the study, they came out from the office without having any problem at all, 0. That's what happened in 83% of the cases. On the 17% of the cases, we had the majority of them complain about the speech, as we anticipated to you, 7%. and then some from chewing difficulties, that is normal at the beginning, of course, and then some tenderness masticatory muscles, that is within a couple of weeks. Then, between 2 and 8 weeks, look, just one person talking about the speech, and 3 people just muscle and joint fatigue. Because at the beginning, we have stretched the muscles, of course, increase the video, and that is very possible. That's between 2 and 8 weeks. But after 1 year, only one person, the same one, was still talking about the speech difficulty. Can happen, 1 every 100, no problem. But even this guy, lost control, had no more any complaint about that. So I solved the problem anyway. It's also interesting about the parafunctional activity. 44% of our patients that we have treated were with the they had the parafunction. And at the end, 17% only still with the parafunction. Could happen, not because the proximal activity is so related to the occlusion pattern, but in some way we have some relation sometimes. You cannot say that this never happened, that the occlusion plays a role. Probably plays a role in these cases, and we had an improvement of this situation here. 17% only were still having parafunctional habits. And no new diagnosis of parafunctional activity was seen in the patient. So now this is the case again. Our patient is Max. And the question that we ask ourselves, we discussed about vertical dimension. And we said, can we do it? And we said, yes. And then you said, how can the side mount? I said, just clinically speaking, 3.5 millimeters is normal to have a new teeth with a regular length. In this case, Max was increasing more than 3, about 6 anteriorly, because it was lost a lot of tooth structure. And what else? He said, how you tested? We discussed already, we have seen what? We have seen the mock-up. You can test with the mock-up perfectly. So, but then there is another question. Increase the video. It means that it's lost if you have increased it. Or it means that you have to increase it anyway, even though it's not lost. Because in this case, we have lost some tooth structure for sure. But until the teeth are grinding each other, are still together in contact, and they're shortening, many times there is a kind of compensatory phenomenon of new bone apposition from the cementum of the roots that can create a kind of over-eruption, the structure underneath of your roots. So more bone formation. So in some cases, even though you have teeth that are completely grind down, they have not lost the video. That is said by many authors, as you could see from this picture. If the eruption occurs at the same rate as tooth rate, the video remains unchanged. If not, the video may decrease over time. So depending on that, depending on how fast is the grinding procedure. And you see here, beginning and after. So the teeth are shortening on the right side, much shortening, and the A is not occupying the entire arch because you have more bone. You have more bone, so you have more bone formation and less tooth height, but still are compensated. 100%, in some cases 80%, in some other cases 60%. Not easy to see, not easy to understand. So with the mock-up, we did the functional optimization. The patient was happy with a smile, a new smile of the patient. We tested also functionally, not just aesthetically. We kept the cervical area untouched. We want to go with our margin until the CJ. We're not going to the cervical recession because we can do this kind of covering of this root later on periodontally. And actually, we do this kind of work in an easy way. Now, after having analyzed all this, I would like to repeat, what about the functional analysis? What we have seen together in this lecture. First of all, we have defined MIP, maximal expression position, the acquired habitual position, and then we have discussed about the CR, when, why, and how. Okay? We have also called and defined the adapted eccentric posture in the case that disc is completely and definitely, permanently displaced anteriorly. And then we have discussed about occlusal scheme, the simplified occlusal scheme by Wiscott with at least one contact per tooth on the buccal cusp of eccentric cusp of the lower arch. And then we discussed about anterior guidance and group function. What is the reason why we use the group function and the cuspid guidance? In the healthy tooth and the healthy joint, we normally use the cuspid guidance or at the maximum the group function up to the second premolar. That allows you to have a quicker, a more comfortable mastication, but you have more load on posterior teeth. We know that, that's with the group function, of course. Anterior guidance should be as flat as possible. Of course, you have to remove any kind of interference on posterior during excursive movements. But at the same time, you should be as flat as we could, because you remember, for every 10 degrees of change in the angle of disclusion, more flat it is, you have 35% of less load on these teeth. And because what we do is to do restoration in place, we don't want to have any fracture. So you have less load, less fracture for sure. That is absolutely possible. And finally, last but not least, we understood that the vertical dimension is a very important step to be used if needed for aesthetic and functional reason, because we can really avoid to devitalize teeth, to do any surgical lengthening procedure. We can be the ability, having the space to occupy the space, increasing the VDO without touching practically the teeth underneath, so maintaining the tooth structure that are still there without destroying completely the case. But in this way, you will restore without destroying. That is just great. And sometimes you have also the chance to avoid even to do anesthesia, because you don't prepare the teeth as you should be. But that is also the content, the topic of another lecture. I hope that you enjoyed the lecture. We see you next. Ciao.